Here. Hey, this is Justin Rapoff, St. Louis Elite Medical Systems Medical Director. This is going to be a discussion on tactical medicine and kind of training for EMS personnel specifically. I've found a lot of TECC seems to be more geared towards, the police and those type of first responders. So this is to hopefully help kind of bridge that gap between our EMS knowledge and what we're seeing in the tactical environment. My road to home to get to where I'm at, and in my background in this kind of stuff, I'm an emergency medicine residency trained, but I actually also did a tactical medicine fellowship there at Cook County Hospital. In doing so, I spent a couple of years working with the Cook County Sheriff's Department, HBT, Hostage Barricade Terrorism Team, as one of their team doctors. So I got to train and, practice movements and go out on call outs. The SWAT teams, of course, and similar in this area, not only do they do SWAT call outs when they're summoned by police, but also, movements with CIA, movements with the FBI, that kind of stuff. And then I, of course, went through basic and advanced SWAT school, so get my TEMS training and stuff. Fortunately, it's been in the past, and I was not able to find any pictures, but I did some other, did my initial training with the SSERT team on the south side, but then I also ran a little bit with the NIPUS with Northern Illinois Police Association. So key concepts in tactical medicine, you want to focus on integrating the medical care with the tactical operations. A lot of this stuff comes with the risk benefits, of the hostile environments. So knowing your equipment, knowing what your capabilities are, if you've been in and around SWAT teams or you've trained with them, knowing, where to go and where the safe zones are, adapting, our protocols and what our abilities are basically to, the SWAT environment. Thankfully for our purposes, for SEMS, we don't have any mother may I in our protocols. It's all stuff that if you have the ability to do, you have the ability to use. So there's no call-ins for this kind of stuff. So, if you're in a situation, if you have the equipment, you're kind of able to do and able to act. And then one of the biggest part is kind of the emphasis on initial survivable injury treatment, that kind of stuff. We'll talk about that a little further here in a bit. So some of the characteristics of the tactical scenarios, the active shooter, active killer type incidents, your hostage barricade are common ones, and we've had a couple of those here recently in this region. High risk warrants is another one that we see a lot of our EMS teams get deployed in the area when they're doing a high risk warrant on certain individuals. Of course, we've had civil unrest and things like that in the area. It's not a if, it's a when type of thing for a lot of these things. Hopefully in the middle of the country, we're limited to terrorist incidents, but, especially with the ongoing wars currently and some of the bombings going on, we know for sure in the state of Missouri alone, there is at least 3 or 4 training centers for ISIS, and they are well known, well tracked by the FBI, that kind of stuff. So we know there's individuals here in the country that are associated with those kind of things. So, and then, again, some of these things, specifically natural disasters, there are security concerns when you have a lot of equipment, a lot of treatment, a lot of medications, that kind of stuff. So those can, in a hurry, turn into tactical medicine type environments. So initially, when you get on scene with these type of situations, usually there will be a command center, and the command center will hopefully give an idea of kind of where the hot zone, or what we call the direct threat area, is located. The warm zone, your indirect threat area, and your kind of cold zone or evacuation center or evacuation area. The hot zone, the direct threat area, that's where bullets are flying. That's where things are, really truthfully happening. The warm zone is the area that can expand into the hot zone in a hurry, but there's no active bullets flying. And then, of course, the cold zone is kind of your staging area where, there might be the EMS rigs and the media and kind of the general public and whatnot. Obviously, these in any kind of situation, they're fluid. If you've got movement of the perpetrator, the hot zone, the warm zone can in a hurry become kind of the hot zone. So me personally, my recommendations, truthfully, especially for EMS personnel, if you don't have any protective equipment, stay in the cold zone. The most important part for us, and this is with any scene that we go to, is scene safety. Whether it's a fire, whether it's a tactical environment, whether it's a natural disaster, floods. If we're not safe, then nobody else is safe. One of the things I always kept in mind when I ran with the SWAT teams, because I had a couple of other docs that used to run with us as well, and they would get in the stack. They would be fourth or fifth or sixth in the stack. I'm never going to be the fastest, the strongest, the best shot, the best at taking down people, the best at handcuffing. But what I am going to be when I'm on this situation is the best at medicine. So that knowing your role and knowing what you bring to the environment, I think is important. In as much as when I used to run with the SWAT teams, I was younger and full of piss and vinegar, and I was ready to kick doors down and cuff people. But in retrospect and reflection, again, we're the best medicine on scene. We're the people that if we're injured, who's going to take care of us, type of thing. So keep that in mind and make sure keep yourself safe. So there's a lot of challenges, specifically when you're in this kind of tactical environment. Obviously, the limited patient access, the ongoing threat. You may still have, there may still be a perpetrator up, as we're having to already treat victims and treat people that were injured. The other part of it is resource limitation. The gear that you're wearing is basically all that you have, and the bags, and this is kind of an example of a bag. This is not mine, but it looks pretty similar. They're really geared towards what's the initial evaluation, initial treatment kind of stuff. And you can see it's relatively limited. A lot of stuff for hemorrhage control, a couple things for airway, and then the rest of it's kind of get up and get out. You don't have a monitor, you don't have defibrillator pads, you don't have all the stuff, all the medications that we have kind of on the walls of our rigs. So your resources are heavily limited. Obviously, like any scenario, communication difficulties, if it's loud, if there's gunshots, if there's a fire, that kind of stuff ends up being a thing. And of course, time constraints. You want to get in, you want to get out. So let's say you've identified a patient, you're in the warm zone. I think most of our districts have protective gear. Again, my recommendations, if you don't have protective gear, stay in the cold zone. If you have protective gear, that's okay to go into the warm zone. The only people, I think, in my opinion, that should be in the hot zone are those that are armed. Now there are, and when I used to run with the SWAT teams, we had the ability, after we trained and did the FBI qualifications, to carry a long gun and a short gun. But again, in my opinion, I'm not going in the hot zone unless I'm armed and capable of defending myself if it comes down to it. So let's say you like most of our districts, you have the protective gear, you've got a vest, you're able to comfortably go in the warm zone, and you see someone in the hot zone. What's your initial assessment? What's the first plan? What do you see? Let's say you see an injured officer, it's been shot in the leg, and he's in what we consider the hot zone. What would be the first thing that you would do?
So is he behind cover, or is he an open target type thing where you would go in and then
he'd
be shot as well?
Let's say he's open.
Open?
Yeah, so let's say he's an open area.
That's my opinion, that's a difficult situation, because look back at the skateboard firefighter back in the 2000s, whatever.
Right number.
Thank you. His name for moment is that they were trying to get to him and they were getting shot. So it comes down to, is that same thing? You have a hazmat situation or whatever, is that you can't go out to them unless you have them there far. It took an AT, a big vehicle to have them have cover to go and get. So the things that have been described in Firewise is the fact of like pulling a pumper up and throwing bags underneath the pumper to kind of disrupt ricochet and things of that nature, to kind of give you some kind of cover to get there. But if it's open, you have no way of providing cover for yourself. Treat it as like a hazmat scene or a violent scene. Safety first.
You bet. So
make voice contact, see if you can extricate yourself out of it.
There it is. Voice contact. And you guys are both saying the same stuff. There it is. So in the initial, and I'm glad you guys went down that pathway, because usually the initial reaction is we got to run out there and grab them. It's like, wait a minute. You got to pause. You got to figure there's still bullets flying. We're in the hot zone. So initial contact is absolutely the first thing you do. So, hey, are you injured? Can they talk? And you're going to do initial, not your full neuro assessment, but initial neuro assessment. Can we have a conversation? Can you follow directions? Yeah, I'm injured. I'm shot in the leg. Okay, can you self-treat? Most police officers have been trained in tourniquet applications, even just simple exsanguination type applications of pressure dressings. Most of them will carry tourniquets. Yes, I'm shot in the leg. Yes, I have a tourniquet. Okay, I want you to apply the tourniquet to your leg. So they're following commands. They're able to do things. All right, next, and just like you said, can you self-extricate? Can you get from where you're at in an unsafe area to a more safe area where we're in cover? Can you get yourself over to me? That's that's the third part that you're going to do. And we ran these practice drills, and truthfully, the first time I did these, I went out and they're like, okay, you're dead. And I went back, like, okay, reset. And I went back like, all right, what the hell did I do wrong? Went out again. All right, you're dead. It's like, all right, well, okay, I got to figure this part out. All right, now I figured out I got to do this initial assessment. We got to, assess the person from a distance. Can we communicate? Can they follow directions? Can they self-treat? And then, if they can't self-extricate, a lot of us we all had similar gear in the SWAT teams. A lot will have a hook on their belt or a tactical type of belt that's designed. You can throw a tow line out to and actually literally physically reel them into safety. So something to consider. Again, this comes back to, priority number one is keep ourselves safe. So do that initial assessment. See if you can get them to come to you, get them to self-treat, and get them into at least the warm zone, if not the cold zone. So let's say we got a different scenario. You got a police officer that's been shot multiple times. You were able to throw a tow line out and tow him to the cold zone. So you're in an area where you're able to assess him, but he's losing a lot of blood, not answering questions, a bit confused, a bit combative. He's starting to get pale. He's got blood coming from the right leg, blood coming from the chest, breathing fast, some shallow breaths. What's kind of your first intervention? What's that? Stop the bleeding. What else? What else? What's that?
Load, prepare to go.
Load, prepare to go.
There are actually studies now that say keep your stuff established and the blood, and if the load goes, going to be on the weight side here. There's the new studies I've been reading.
This is a
airway.
Treat.
This is a bit of a trick question.
Circulation and airway breathing.
And I gave it with confused and combative. This is something we don't think about. Disarm the officer.
Oh, yeah.
Very first thing, we got to think about our personal safety. And that's what that's one of the things I want to keep coming back to. We got to be safe first, and this is something that we train in specifically. And when we run scenarios, we'll have a pretend officer that will go out and will pretend to be confused. The thing to think about with these kind of things is a lot of times, our SWAT team guys will have a long gun. They'll have a pistol usually on their sides. And sometimes they have one hidden somewhere else too, on the leg, in the back, something like that. So give them a quick pat down, give them a search, make sure that we've disarmed them, make sure that they don't become an active threat to us or to anybody else around us. But then, then it's the XABC. Worry about the exsanguination. That's the most common cause of initial killers. Then we do our airway, breathing, circulation, neuro, all that kind of stuff. So again, a bit of a trick question, but our safety comes first. We got to make sure to keep, even though this is somebody that, yes, this is a good guy. They're on our team. When they're combative and confused, they now become a threat, especially if they're armed. So initial care under fire, there's kind of three phases. You got your care under fire phase. That's the initial where you're in the hot zone, or if you can carry, you're in the warm zone at a minimum. Obviously, primary objective: seek cover. If you're in the hot zone or even in the warm zone, make sure you've got somewhere that you're behind. Hemorrhage and bleeding control is the absolute most important thing in this type of scenario. The vast majority of studies have shown that exsanguination is the most common cause of preventable death in these type of scenarios. So, being really familiar with your tourniquets and being aggressive, truthfully, with them. But also, I like the Israeli bandage. There's, any kind of quick clot, any kind of the bandages and good firm pressure. Airway management, if you've got somebody that's unconscious, when you have a limited backpack, we usually keep an oral airway or two, but also, maybe an LMA or two. We don't carry stuff to intubate. We don't carry, endotracheal tubes, that kind of stuff. This is purely just to keep the airway open. The second most common cause of preventable death is airway obstruction. So even an OPA, just something to open up their airway, keep their tongue off, off the back of their throat, turn them in the recovery position, put them on their side, that kind of stuff. And then move the casualty to cover when tactically feasible, specifically. So again, tourniquets, pressure dressings, practicing your drag techniques, especially, it's a different story when you've got a 200-pound, plus guy with all of their gear, could be 250 to 300 pounds. Trying to get that limp person to a safe location is something that's a chore and usually a couple man job, and then making sure you have good communication. That's kind of the initial care under fire phase. The secondary phase is your tactical field care phase. This is once you've gotten to somewhere that's covered, somewhere that's more safe, then you can kind of expand out into your XABC, X for exsanguination, your hemorrhage control, airway, breathing, circulation. Then you worry about the disability, the neurologic type stuff, and even specific exposure. Obviously, here in the Midwest, we got some of the toughest people on the face of the planet because we have some of the wildest weather swings. This is one of the few places that can be 20 and then 20 degrees, and then 24 hours later it can be 80 degrees. So, we can deal with hypothermia and hyperthermia really within the same 24-hour period. And there's not many places on the planet that have to deal with these kind of weather extremes that we have here. So, and keeping in mind too, somebody that's wet, their exposure, especially to colder weather, you're 25 times faster loss of heat and through evaporation and through being wet. So, make sure to work, keep an eye on that kind of stuff. So I'm a huge advocate of tourniquets. I did studies in tourniquets. I practice tourniquets as much as I can. I have tourniquets in all of my vehicles. I have tourniquets in all of my medical kits and stuff that I've had. I've had to apply multiple in the ER, not in the civilian environment, but I know we've had many, numerous lives saved with tourniquet application. Tourniquets kind of got a bad rap, really in the World War I, World War II, because they were thin, because whenever you had a tourniquet applied, it was basically like, all right, you lost that limb. That just kind of was the thought. Partially because they were too thin, partially because they left them on too long, partially because our medicine just wasn't as good as it is now. We've got much better tourniquets. We have much better, wider is better. Getting them off within 90 minutes is usually our goal. I like to do 2 to 3 inches above the wound itself. Irrespective of when and where, we would consider, if you're putting a tourniquet on, that's a life-saving intervention, but that person may lose their limb. If you can put a tourniquet mid-forearm, if there's a distal, forearm wound, if you can put it mid-forearm and they have most of their arm, is better than if you went all the way up in the axilla and they lost their entire arm, if that's what it comes down to. If given the choice, I'd take survival over not having my arm, obviously. You turn the windlass until you have loss of pulse and loss of blood. Something I want everybody to do a little homework on. Check and see if you have a plastic. The windlass is that piece that turns. Check and see if you have a plastic or a metal one. I can tell you from breaking multiple of plastic windlasses in my lifetime, because once you crank it to the actual correct pressure, I really only recommend there's, lighter weight aluminum ones. They're only a couple dollars more expensive, but most of the time when people are ordering these, they go with the cheaper one, and it's the plastic bullshit ones. And I've seen, even us practicing, we've broken multiple windlasses. So what happens if you got a tourniquet, you apply it and you break the windlass, or you have it as tight as it can go and you just really can't get any more out of it, but it's still bleeding? You put a second tourniquet in sequence. When you have more pressure over space, and it becomes a physics equation, and us as firefighters can understand that the physics of pressure over distance is what really can help tamp that wound down. One of the things that I do specifically, anytime I have somebody that has a tourniquet, it should be marked on the tourniquet itself. There's a spot that says time. I write their time in marker on their forehead. that's something that, not only do I do that, but I put it on the whiteboard when I'm in the ER, and I put it on the room just so everybody knows. Because the first thing when you walk in and talk to the patient, it's not at the tourniquet, it's not the whiteboard. You look them right in the face. And when you see the T time, I usually put T and then, 9:37 a.m. So then it's readily apparent to everybody that walks in there that we are on a clock, and we absolutely need to get this patient to the operating room, to vascular surgery, to whoever needs to go in to fix this wound, because usually we consider about 90 minutes to be the ideal time to let that thing up and to reassess and make sure we get them to the right disposition in the operating suite. So tourniquet time on the forehead. And then, of course, using hemostatic agents. There's all kind of quick clot and, different. I don't have a dog in the hunt. Truthfully, there's a lot of great ones out there. There's pretty good studies that most of them work pretty similarly. So, find your hemostatic agent of choice and good firm pressure. Most wounds, even venous bleeding, will stop with good firm pressure. It's really only arterial bleeding that requires a tourniquet in most situations. And then, of course, combining pressure dressings, instead of replacing dressings, put more on top and continue to put pressure. Again, hemorrhage is the leading cause. So in these kind of scenarios, being comfortable and able to apply tourniquets is one of the most important things you can do. I like these Israeli bandages. They're not expensive. I think I bought 4 of them for $25 the other day. I keep these in my vehicles too. It's not quite a tourniquet, but it's a really damn good pressure dressing, and it's designed. We carried them with our SWAT teams. Again, I don't have a dog in the hunt, but it's designed to be self-applied, which is nice. It's got a nice firm area that you can absorb whatever wound, but also you can wrap the thing back on itself. Excuse me, and you can even twist that plastic piece to kind of even get more pressure. But something I carried in my bag just in case, and I've used a couple of them. I think it works nice as a pressure dressing, especially in an environment where you have very limited resources. Airway management, one of the few things we did carry was a scalpel in case you needed to do a cricothyroidotomy. But oral airway and LMA, usually suffices in that kind of scenario. Chest decompression is another thing that's the third most common cause of preventable death in these kind of scenarios, and that's a pneumothorax or tension pneumothorax, usually specifically. So watch late signs are kind of the tracheal deviation, but loss of breathing. When you increase the intrathoracic pressure, blood pressure goes down. Once blood pressure goes down, heart rate goes up, mentation goes down. These are all kind of in conjunction. Now, again, keeping in mind when you do a needle decompression, if there wasn't a pneumothorax there now is. So something to keep an eye on. Getting IV access. And then, of course, pain management and hypothermia prevention are important as well. And then tactical evacuation carrier. This is kind of the cold zone. Secure the area for transport. Make sure to do a reassessment. Any of the other advanced life support interventions. This is the area that you're going to have your rig. You're going to have your monitor. You're going to have your AED. You're going to have all the things that you normally have when you're on an EMS call. Obviously preparation for hospital handoff, making sure you can, start your documentation. And I've only thankfully been in a couple of times in a disaster type situation, but usually what I do is I'll just get a piece of paper and I'll either write the name, or if I'm at the hospital, I'll grab stickers and just kind of put stickers and just write a word or two so I can remember that patient. Obviously documentation can be done after the scenario, and, people would much rather you act and do work rather than worry about sitting and documenting. So obviously harder to do when you're on the backside of things, but doing your best job is important. And then communicating to the receiving facility, making sure that how many people they can take in a disaster type scenario and what their capabilities are. So things to consider when you're transporting. You may have route security, and this is something that the on-scene command should have evacuation routes that will be safe from kind of any bullets flying or any structure fire or anything that is necessary to help get our patients out. Of course, medical equipment availability, knowing what hospitals have, what capabilities, what specialties. Even emergency departments that don't have trauma centers still have emergency medicine physicians that can stabilize and treat in the interim, especially in these kind of scenarios. If you have too many patients for the trauma centers, then other facilities may be relied on to at a minimum triage and take care of some of the initial interventions for these casualties. And then, the other part of it is sometimes the casualties have to be evacuated by either police or pumpers or, even sometimes civilian vehicles to get to the hospitals if we're in such extreme situations that, we don't have enough rigs to be able to transport initially. So equipment considerations, again, this kind of depends on where you're going. IMO, if I don't have any protective equipment, I'm staying in the cold zone. I'm staying off site. If I have, then I would recommend a helmet and at a minimum, your vest. If you're going to go in the warm zone and then to go in the hot zones to be armed. These are heavy. When you're talking about a vest, a helmet, if you have the plates in the front, plates in the back, your bag, this can be up to 100 to 150 pounds worth of equipment. So, these are things that we don't do often enough, but at the shop, at the house, if you're going to do a workout, go do some movements in your gear, figure out where things are, figure out where you like the placement of stuff too. Truthfully, we would do a lot of movements and practice in our gear. And I found that, initially I had, my tourniquets on the very front of my vest, but if I had to do anything prone where I'm on my stomach, that was really uncomfortable and I'd have to roll to one side or the other. So, eventually I landed on, well, they fit better kind of on the side, flanks of my vest. So do movements in your work. Don't let the first time that you're wearing your protective equipment be on a call out, because that's not the time to learn your type stuff. Learn it prior and be comfortable with it prior. Again, load bearing considerations, just when you got, this is a lot of weight, it can be up to 100 and 150 pounds worth of stuff. And that's not even considering, are you carrying extra magazines? Are you carrying, a short gun, a long gun, that kind of stuff. So recommended for your equipment itself, at least 2 to 4 tourniquets per provider. I think, we always have equipment for other people, but you always need to make sure there's at least some for yourself. That's one thing that I think a lot of police officers will carry 1 to 2 at a minimum, so they can self-treat and have been trained in as such. Make sure you have your hemostatic agents. Again, pick your agent of choice. Have plenty of pressure dressings. Kerlix are great. Those Israeli bandages are great. Have something that you can apply and put some tension on. Having chest seals, of course, is important. These are one of the tension pneumothorax and open sucking chest wound is a common cause, especially in disaster type scenarios and in tactical environment, common cause of death. Make sure you have your decompression needles. I would have at least 2 to 4 of those as well. And then of course your airway adjuncts. There's some really great pre-sold kits out there, but they're truthfully, if you're going to put one of these kits together, it's cheaper to order things individually. They're happy to sell you one pre-done, but most of them are relatively standard. Make sure you have scissors, make sure you have marker, make sure you have some hemostats, make sure you have, a smaller pair of something to cut. I would have even some sutures and things like that, in case that needs to be used, and make sure you have the IV, IOs type supplies as well. And then the other part is make sure everybody has the same setup. So if you're on a SWAT team, or if you're on a TEMS team, make sure everybody has the similar setup, because these are ones designed to go on your backpack. I had one that I could clip here and unclip it, it would fall off and I could work from, but they're also designed for, you can unzip them and somebody can work from your back as you're working on somebody else type of thing. So having things in similar spots is important as well. So some of the challenges of airway management, of course, if you got a helmet, if you've got limited space, truthfully, some of the first intubation challenges we did were with our SWAT teams. That's kind of where those ideas came from. And doing these when you have your equipment on, using the jaw thrust, using your nasopharyngeal airway, using your eye gels, are all kind of options. Surgical airway is kind of the last resort, but has to be done on occasion. And then making sure you have good C spine if you've got a fall or a spinous injury is important. And of course, you got to consider the ongoing threats as well. These are environments. While you may be in the cold zone or the warm zone, they're fluid. Things can change as perpetrators will have different movements. So, being aware that doing medicine's one thing, but doing medicine when you're having to consider your surrounding environment and potential threats is another. So, puts a little bit more time on the clock. So in terms of chest trauma management, again, tension pneumothorax is the third most common killer in these kind of situations. Usually decreased lung sounds. Usually they will get more and more short of breath. A lot of times will be associated with a penetrating wound, whether it's a knife, a bullet wound, that kind of stuff. Again, the tracheal deviation is kind of a late sign. But usually once you get that, then the entire chest cavity is filled with air where air not supposed to be. And it's pressuring on the other structures. It's causing hypotension, causing some decreased mentation. That's the time we need to act. So the needle decompression, again, just as a reminder, we recommend in the fourth, fifth intercostal space, kind of mid-axillary line. This is the area that is usually the most safe to do. This is the area we usually put chest tubes and things like that. So much higher incidence of success when we go that area versus the first and second intercostal space. And then, of course, when we get to the hospital, prepare the chest tube. One of the things I want to talk about, kind of the open sucking chest wounds, the open pneumothoraces type of thing. So pneumo means air. Thorax is the thoracic cavity, the chest cavity, essentially. So open air in the chest where it's not supposed to be. So why do we need a three-sided occlusive dressing? Well, what happens is you've got a situation where our lungs work by negative intrathoracic pressure. So what happens is the diaphragm will actually pull down and it sucks air in through the trachea, through the bronchioles, and inflates the lung in that manner. Well, what happens when you've got an open wound is instead of when the diaphragm moves down, what happens is you'll get air that will preferentially come in through that negative intrathoracic pressure and push on the lung itself. So why we need a three-sided patch and why a four-sided one doesn't work is when you have the diaphragm again that moves down, the third side that's open will actually suck to the chest wall, will prevent any air from coming in and will allow air to come in the proper way. But whenever the patient breathes out, what happens is this area will open up, air will come out, and this will help essentially resolve the pneumothorax on its own. So that's kind of I've had that question a handful of times of, kind of what exactly is happening. What's the physiology of what's going on with this three-sided wounds? That makes sense. Yeah. Okay. So kind of what's the physiology and what's happening in the three-sided chest seal type of thing. So that it really comes down to kind of the mechanics. A lot of people think that, well, our lungs fill up and air is forced in there and that's why they fill up. It's like, no, that's not actually the case. It's the negative pressure of the diaphragm going down and sucking air essentially in. So that's really where we get the changes. And then of course, the other thing, pain management, in this kind of a setting. Are they altered? Are they a security risk? You want to take care of patients' pain. Can they take pills? Tylenol, ibuprofen are fine. Fentanyl for severe pain. I like fentanyl. And in terms of a lot of the opiates, it's the one that has no histaminergic release. The thing about morphine and Dilaudid is both of those have a bit of a histaminergic release. So especially in trauma type situations, it can drop that histaminergic release, can drop their blood pressure. You can use that to your benefit on other cases, but if you got a patient that has been shot, has been stabbed, has been, that kind of stuff, we kind of need to know, did they drop their blood pressure because of the medication, or did they drop the blood pressure because they're losing blood? So, that's why I prefer fentanyl in those kind of situations. So the TCC is kind of the military application of these tactical medicine type stuff. And one of the things that Drew talked about a second ago that I kind of want to touch on too was there has been more of an emphasis on blood over fluids, and this is most traumas in general. But let's say we're a container here, and I've had some sort of an insult. We'll say this is a knife, and I've lost 20% of my blood volume. If I replace that with normal saline, what's the oxygen carrying capacity of normal saline? What's the ability to clot for normal saline? It's none, and you've now added back in. Yes, my blood pressure is better because I've added more fluids in, but the problem is now I have more pressure on the clots. Now I have more pressure to, unfortunately, help exsanguinate if you've got open wounds or if you've got a tourniquet on, that kind of stuff. So in the trauma environment, and we're using this concept in a lot of GI bleeds and other things, we call it permissive hypotension. If the patient's mentating okay, they're probably okay to get 500 of normal saline. That's kind of the line we've put, but really no more. It really comes down to the blood, and we've got blood in our protocols. Getting blood on scene has some challenges, but we've got multiple districts in the area that do have blood, and I think in these tactical scenarios, we'll easily have a chance to call the BCs and the captains and folks that have the ability to give it in the pre-hospital environment. So giving blood is definitely in your protocols. So, and then of course integrating with the law enforcement. Make sure you got a clear command structure. Making sure you're using tactical frequencies. Make sure we're all on the same kind of radio line. Understand what their priorities are, and helping coordinate movements between our TEMS providers and our SWAT teams or our police force. There's a lot of different methods of this. There's some tactical EMS teams that it's just an EMS team of TEMS providers. There are other teams, and this is kind of what I've done in my past. It's where the TEMS providers and the physicians are actually embedded within the team itself. So we're actually in the stack. We practice movements, we practice clearing rooms, we practice that kind of stuff. So, and truthfully, usually the physicians and TIMS providers will be in the back of the stack. But once you start clearing a school or start clearing a church or office buildings with a lot of rooms, usually we clear with at a minimum 2 people. And even if you're 9th, 10th, 11th, 12th in the stack, if you're helping clear rooms, you're at the very front of the room in a hurry, and especially it's usually the perpetrators are usually not in the first couple rooms. The perpetrators are usually somewhere in the distance. So you very much, if you're in that kind of situation, you go from end of the line to the front of the line in a hurry, especially in those larger type buildings as you progressively clear rooms. Then of course, there's strike teams. Here in this region, we've got the strike team 1. Myself and a number of other medical directors. Whenever we have these kind of disaster scenarios, we spend time. I'm usually off in these kind of disaster scenarios, whether it's riots, whether it's that kind of stuff. I've spent a number of time on a rig off site, and I'm there specifically for our first responders, whether it's you guys, whether it's our police, so if one of us gets hurt, then the physician and that's strike team 1 will be there first to kind of take care of our people. And then, of course, the collection casualty points. So some of the legal considerations to think about with this, the good news for us, in these tactical situations, the EMS portion of it, you've got all the equipment, you've got all the abilities, there's nothing in there that you have with you that you can't do. Now there are certain teams that will do some expanded procedures and to do that kind of stuff, you may need a written authorization or whatnot, or documentation or that kind of thing. But thankfully, like I said, for the most part, we don't have any mother may I's. You're able to kind of do what you need to do in these situations. But then you run into the ethical dilemmas, and I've had this happen plenty of times where you're treating a suspect or you're treating a known perpetrator. So then sometimes it comes down to the resource allocation. If we've only got one tourniquet, or if we've only got one bandage, if we want, who gets what in those kind of situations. Thankfully, for the most part, in the civilian environment, we don't nearly have these challenges like they do in the military environment, but things to consider. Thankfully, there are the Good Samaritan laws, and these kind of cover us and all these kind of situations where even if you stop on the roadside and help somebody or help somebody at Walmart, or as long as you're doing things in good faith and practicing within your scope of practice, if it comes down to it, the Good Samaritan laws kind of cover us in these type of situations to basically just be good people and good stewards of our times, talents, and skills. So other ways to kind of train and prepare, the TCCC certification and course is good. Obviously, the TECC course is great. Practicing your hemorrhage control and those kind of courses, making sure you have, you're comfortable with your airway management, and then, your physical fitness. I put a slide of the batting cage here because I consider a lot of this stuff. It's like taking batting cage reps. You can't go, hit dingers or hit home runs when you're not taking your practice reps. You're not practicing with your equipment, not practicing with your gear. So practice like you play. So key takeaways, obviously we come first, provider safety, make sure we consider the continued threat assessment, always focus on the life-threatening hemorrhage control, and then airway management, and then, kind of finish off with team communication. Success comes with training, preparation, and equipment familiarity. So here is the QR code for the CMEs. We'll make sure we post this on my YouTube channel. Questions?
So I know all the technical training I've had has been more on the fact of like EMS and fire. I've never been on a TAC team. So we always talk the fact of just got hurt there. So trying to
You want me to go back to it? Sorry, yeah, I can go back to it.